video lecture for microbiology for the class that meets on Tuesday, the 13th of, that's the 13th of November, and we're talking about the chapter on antibiotics. So here we go. Okay, so if we look at different modes of action of antibiotics, one of the modes of action is targeting the cell wall, and there's a lot of different antibiotics that target cell wall formation. I will present some chemical structures here, but it's not necessary that you know the chemical structures. Penicillin, there's lots of different types of penicillin. There's penicillin G, there's penicillin A, there's penicillin Y. And if you look at anything that has a cillin associated with it, it basically has the same backbone chemical structure. That would be like amoxicillin or penicillin. Anything that has that suffix basically has the same basic structure. And then the side chains are varied, and that gives you the different types of penicillins, or different types of the cillin group. All penicillins have a thiazolidine group and a beta-lactam ring and a variable side chain. And you can see thiazolidine and the beta-lactam ring. Again, I'm not really concerned that you know these structures more than I am that you understand the modes of action of these different antibiotics. Penicillin G and V are the most important natural forms, and these are good for sensitive gram-positive cocci. They will work for some gram-negative bacteria. And ampicillin, carbapenicillin, and amoxicillin, you probably have heard these before if you've ever had like an ear infection. These are used quite commonly in ear infections, and they're better broad-spectrum antibiotics. Okay. A lot of bacteria, including almost all strains of gonorrhea, produce an enzyme called a penicillinase, and this type of enzyme breaks down penicillin, and so therefore it can't be used in the treatment of penicillinase-resistant bacteria. Those that you use in the case where penicillinase is present would include methicillin, ampicillin, and cloxacillin. So these are all options that you can exercise if you are using something that would normally be susceptible to penicillin but is resistant. Okay. You've probably heard of the super antibiotic augmentin. Augmentin is just amoxicillin plus clavulanic acid, and clavulanic acid is a substrate that inhibits penicillinase, and it allows you to use amoxicillin much more effectively. Cephalosporins also target cell walls, and these account for probably the majority of the antibiotics that are being administered today. These come from a mold called Cephalosporium acremonium, and they are relatively broad spectrum, and they cause fewer allergic reactions. They're resistant to most penicillinases, so they can't be broken down by penicillinase activity. Some are administered parenterally, which is by injection into a muscle or a vein. However, the majority of these cephalosporins you could just take orally. Okay. The newest generations include Keflex and Rocephin. Rocephin is good for respiratory infections, skin, urinary tract infections, and nervous system infections. Okay. Other drugs that target the cell wall include bacitracin, and interestingly enough, this is produced by good old Bacillus subtilis, And if you use Neosporin ointment, that you're basically getting bacitracin treatment. And these are good for Streptococcus and Staphylococcus, and so they're used in ointment for skin infections. Isoniazid is a bactericidal for Mycobacterium tuberculosis. It's not used as much anymore because rifampicin, which targets, I believe, RNA synthesis, has displaced it. And then vancomycin, which is really, really the big guns, is an antibiotic that is very effective for staph infections in patients allergic to penicillin. And this is given sort of as a last resort. When you know somebody has MRSA, then they usually start IV vancomycin to deliver that to the site of infection. And it is very, very strong. It's toxic. And so when somebody has a life-threatening infection like a bone infection or a serious MRSA infection, then they will give them vancomycin because it has a lot of toxicity issues. Okay. Fosfomycin trimethylene is usually called Fosfomax, and that's an alternative treatment for urinary tract infections. Okay, it's another mycin. You hear mycin a lot is in terms of a suffix for antibiotics. Now, drugs that target protein synthesis, this would include aminoglycosides, and these come from soil molds, Actinomycetes, Streptomyces, and Micromonospora. And this includes streptomycin and gentamicin. These, again, streptomycin sounds like it might come from bacteria, but it does come from a type of mold called Streptomyces. And then tetracyclines are semi-synthetic. So they've been produced biologically, but then they've been altered in the laboratory, and they bind the ribosome, they block protein synthesis. However, there's a lot of gastrointestinal distress that's associated with tetracycline, and so long-term treatment, then you can start to see other types of symptoms appear, like Crohn's disease. Okay. Chloramphenicol is a broad-spectrum antibiotic, and it blocks protein synthesis at the peptide level. The amino acids can't attach to the growing peptide, and so protein synthesis is shut down. Erythromycin and clindamycin both have low toxicity and are broad-spectrum antibiotics. Sinercid is good for endocarditis and surgical infections. Sometimes it's used prophylactically after surgery. It binds sites on the 50S ribosome and inhibits translation. Oxalidones, okay, I'm sorry. I should be able to pronounce these. They inhibit the initiation of protein synthesis, and this is a synthetic type of drug. Okay, this just shows you the complexity of these structures. These antibiotics typically are made biologically because it would be very difficult to chemically synthesize structures. So a lot of them come from mold, some of them come from bacteria. In terms of targeting DNA or RNA, fluoroquinolones are broad-spectrum antibiotics. Norfloxacin and ciprofloxacin, also called Cipro, are good for UTIs, sexually transmitted diseases, gastrointestinal diseases, osteomyelitis, respiratory infections, and soft tissue infections. However, you have to be very careful. These can cause seizures and other types of brain disturbances. So these are different factors that your practitioner is going to look at in terms of prescribing an antibiotic. Rifamycin is also, well, I'm sorry, it's not rifampin, it's chemically altered into rifampin, and that's good for gram-positive rods, and it's good for Neisseria meningitidis, carriers. That's Neisseria meningitidis causes meningitis. And so it's used prophylactically for people that carry that particular bacteria. It's also good for Legionella, a bacteria that causes Legionnaire's disease, Brucella, which causes brucellosis, and then Staphylococcus infections. Here's meningitis, which can be caused by Neisseria meningitidis. This would be a bacterial meningitis, and you see these lesions that are associated with nerve endings. Okay, brucellosis affects the joints. You see it a lot in cattle, although there is a human form of brucellosis. And then a staph infection. This is just a pustule, and you can see the yellow color, so it's forming pus. We call that pyogenic. Staphylococcus is a pyogenic bacterium. Targeting cell membranes. Primary antibiotic here is polymyxin. And they just, basically their fatty acid component looks a lot like the cell membrane, so it washes away the cell membrane. Daptomycin is made from Streptomyces mold. It's active against gram-positive bacteria, and it also disrupts membrane functions. For fungal infections, there are a group of antibiotics that also disrupt the cell membrane. These would be macrolide polyenes, and they're specific to fungal membranes. This would include amphotericin B and nystatin. Griseofulvin is active for athlete's foot. And then azoles like miconazolin, which is good for topical infections like jock itch. Okay, and then flucytosine. This does not attack the fungal membrane. It actually looks like cytosine, the nucleic acid, and it blocks protein production. It cannot be translated into protein. Okay, so it looks like cytosine RNA, or I'm sorry, it looks like cytosine DNA, and then RNA cannot synthesize. In terms of parasites, parasites would include things like protozoan parasites, as well as helminths. Quinine or quinoline is a principal treatment for malaria, although you have to catch it in the right lifetime because there is no single drug that will kill Plasmodium in all stages of its life. Okay, Flagyl is specific to Entamoeba histolytica, but you can also use it for Giardia and Trichomonas infections. Anti-helminths. Okay, so sorry about that interruption. My disk was full, so I had to release some disk space. We're talking about anti-helminth therapy. You have to be very, very careful when you treat helminths because helminths have physiology that's very similar to humans. And so it's very difficult to come out with a drug that isn't going to have a side effect on human cellular physiology. In terms of viral infections, there's different ways that you can infect the life cycle of a virus, like inhibition of virus entry into cell. Fusion prevents HIV from binding to cell receptors on cell surfaces. You can inhibit nucleic acid synthesis like acyclovir, which is a synthetic nucleotide that terminates DNA replication. And AZT, which is used for HIV infections. It has the same mode of action. It basically looks like thymine, but it does not allow the DNA to elongate. Okay, so the virus can no longer replicate. Inhibition of viral assembly. So once all of the pieces of the viruses come together, then you inhibit that, or you inhibit the release of the virus from the cell, like protease inhibitors. Insert into HIV protease, and HIV protease breaks down the cell so that the virus can release. So these protease inhibitors block that action. Okay, here's AZT. AZT basically integrates into the position where thymine would integrate across from adenine. and then AZT has no place for another nucleic acid to attach, so that just blocks DNA duplication right in its place. AZT has an instead of a hydroxyl group on ribose, it has an azide group on ribose, but in other fashions, it looks just like thymine. Okay, common side effects for AZT, it's really harsh drug. And it's also given in very strong doses. So you look at different changes in body fat, especially you kind of get this look. It is a lipodystrophy kind of look because of the maldistribution of fat. AZT causes a maldistribution of fat in tissues, so the fat builds up in the upper back, so it looks like they have a hump back, and also you get this kind of sunken cheek look, especially around the nose. And this is just maldistribution of fat. It has nothing to do with HIV. It's just a side effect of the drug to treat HIV. Okay. Another drug that's used against viruses is human interferon. And humans produce lots of different types of interferon protein, but interferon alpha, beta, and gamma have been produced using genetic engineering for therapeutic purposes. It's an antiviral drug. It's used a lot for hepatitis C. It's also an anti-cancer drug. And it plays a role in natural immunity, but only in very low levels. When we use interferon therapeutically, say from genetically modified bacteria or genetically modified cells, then we use much higher doses, and so there are a lot of side effects associated with it. Okay, like I said, it's made by recombinant DNA technology. It's used for hairy cell leukemia, hepatitis C, genital warts, and Kaposi sarcoma in AIDS patients. And this is wild, causes personality changes. Everybody likes that, so you become like Wolfman in your personality. It also decreases white blood cell count. I have a friend that takes human interferon as a therapy, and it basically wipes him out for a whole day. It takes it about once a week. Okay, this is hairy cell leukemia. This is hepatitis. Hepatitis C is a type of hepatitis, and you can see that the liver has become swollen and cirrhotic. So it's basically the tissue is non-functional. And here's an AIDS patient that has Kaposi sarcoma, and you see these lesions. These are actually cancerous lesions on the patient's face and neck. You also, when you think about antibiotics, you have to think about resistance to that particular drug, especially in the context of microorganisms that gain some type of genetic material that allows them to tolerate drug where they would have normally been inhibited by that particular drug. Okay. It can be a chromosomal mutation that happens, or it could be just conjugation or transformation where plasmids are exchanged. And these plasmids are called resistance factors or R factors, and they can be transferred through conjugation, transformation, or even transfection. Okay, and there's lots of ways that these drug resistance genes can inactivate antibiotics. Like here's active penicillin, and penicillinase will just break the beta-lactam ring. You can have a microbial cell that where the drug normally goes into the cell and it adapts so the receptor no longer accepts the drug. You can activate drug pumps, so the drug actually comes into the cell, but there are protein pumps that will pump it out. You can change the drug's binding site so it no longer binds the ribosome, or you can create an alternative pathway to make a product. This happens a lot with folic acid synthesis. There's alternative pathways where sulfa drugs no longer are functional. Okay, and you also have to look at the fact that natural selection applies to antibiotic resistance. you know, we use natural selection to get recombinant uh, organisms and proteins, but the same principle applies here. So drug-resistant cells, if you grow them without the existence of selection pressure, so in the absence of antibiotic, they're going to grow along with the non-resistant cells. But as soon as you grow them in the presence of an antibiotic, then the drug-resistant cells are going to grow favorably, and that's the type of bacteria that's going to spread. Okay, and so selection pressure in this case is just adding an antibiotic, and then the only thing that grows are antibiotic resistance bacteria. So there are new approaches that basically try to circumvent natural selection. One of the ways that this can be done is just to target the iron scavenging capabilities of bacteria. So you just find substances that will block the bacteria's ability to collect iron. And you can't really naturally select around iron scavenging. Organisms need iron as an essential nutrient. And so it would be very difficult for the organism to adapt no longer to need iron. Riboswitches, these control translation of RNA, and by blocking translation, you can kill the bacteria. Also, using probiotics is a good approach. It flushes out the bad bacteria, especially when you have like a gastrointestinal infection. You take a probiotic, it gets rid of the nasty bacteria and it replaces it with good bacteria. Or you can take prebiotics. These are nutrients that feed the good bacteria and starve out the bad bacteria. Okay, and then lantibiotics, which are antibiotics that are produced by other bacteria. And they've been used in food preservatives, and these are now being used as antibiotics therapeutically. You always have to look at the side effects of any type of medicine. Remember, these are toxins, so they are toxic to humans. We're just giving them in lower doses and over shorter periods of time. Okay, tetracycline. This is a tetracycline teeth. Tetracycline used to be used pretty extensively for acne, and it's not used anymore because it turns your teeth yellow. Okay, and this discoloration can be permanent. Anaphylaxis. This little guy has swelling in his lips and mouth, and that could cause swelling in his airway. And when that happens, then he goes into anaphylactic shock. He can't breathe. And then what's called in a hospital setting, this is normally termed C. diff, but it's Clostridia difficile. And Clostridium difficile will form in these little pockets here. And this is a type of colitis, similar to Crohn's disease. And it irritates the colon and causes diarrhea. And Clostridia difficile starts to raise up as you kill off the normal flora in the body. Then normal flora will fight off Clostridium difficile. But in this particular instance, if you give too many antibiotics, that kills off the normal flora, and then Clostridium difficile comes up. So if you ever hear in a hospital environment of a C. diff infection, it's just somebody that has been given too many antibiotics. Okay. Also, drugs can cause damage to organs, diarrhea, which can progress to colitis, arrhythmia or cardiac arrest in severe cases, seizures and brain damage. And despite what some medical professionals might say, seizures are always serious. They say, oh, well, the seizure is subclinical, but a seizure causes brain damage. And so you have to be very, very careful with a seizure. Some antibiotics come with a label to stay out of the sun, and that gives you sensitivity to sunlight, which means that your skin can redden and become bruised by sunlight, and then teeth discoloration like with tetracycline. You always have to bear in mind allergic reactions, especially if an individual is given lots and lots of antibiotic. And in that particular instance, then you would have to switch out an antibiotic to one that's in a different family or a different class that won't cause the same allergy. And then any antibiotic is going to kill off normal good flora. And so when that happens, then other organisms that are in your body can become out of check, like yeast. A yeast infection. Yeast infections are held at bay by normal bacteria. But once those normal bacteria are killed off, then the yeast will start to become infective. Infective yeast is called Candida albicans. And when you kill off your lactobacillus, then the yeast start to infect. Also, as I said before, Clostridium difficile, or C. diff, invades the intestinal lining, and that leads to diarrhea, fever, and abdominal pain. So you have to consider all these factors. First, you have to consider what's causing the infection. So what microorganism is causing the infection? You have to consider what's going to kill the microorganism. And then overall, the medical condition of the patient. Will they survive with a strong antibiotic, or could the strong antibiotic compromise their health? So you might use something that's a little more benign. To identify what's causing the infection, a lot of times doctors will just use epidemiology. They'll consider their caseload, and if they're seeing a lot of strep infections, then they may go ahead and diagnose strep throat based on redness. Many times they'll take a specimen from the body as soon as possible, so they'll do like a throat culture, they'll do a rapid strep strip. And they examine the specimen, and they usually make their best guess determination, and usually this is pretty good. You don't want to spend a lot of time and money identifying a normal infection that you're seeing frequently in your practice. Also, epidemiological statistics, even within a medical practice, if you're seeing a lot of a particular disease associated with a particular area, then your best guess identification may be good enough. So like Streptococcus pyogenes for strep throat. Then you want to do a culture for confirmation, but probably while that culture is incubating, you would want to give that patient a prophylactic antibiotic just in case. Okay, because you want to start treatment right away. If you let an infection go too long, then it can start to cause organ damage itself. Okay. You may have to do testing, but ordinarily, probably 90% of the time, you're not going to test a specimen for drug susceptibility. Okay, fungal protozoan infections, staph, strep, anaerobic bacteria, you probably don't need to do testing for drug susceptibility. But you can do in vitro activity determination. We're going to do this next week via what's called the Kirby-Bauer test. And the Kirby-Bauer test uses just small discs that are impregnated with antibiotic. And they are helpful at determining what's the minimum inhibitory concentration, or the minimum amount of antibiotic you can give to a patient that will visibly inhibit growth, or is going to be effective at killing the bacteria without killing the patient. Okay, and here's a Kirby-Bauer test. You see these little antibiotic discs. Okay, they have little labels on them, like 10 for 10 milligrams or something like that, and also letters that correspond to different antibiotics. And you see a full lawn of bacteria, and then you have these zones of inhibition. These zones of inhibition are where the antibiotic is leaked out into the medium, and they've inhibited microbial growth. And we just measure these zones of inhibition, and by measuring the zone of inhibition, then we can tell whether the antibiotic is working or not against a particular bacterium. Okay, and so I want you to pay very careful attention at this particular table, because there's going to be something like this on the exam. So if you have a drug like bacitracin, you know that the zone for susceptibility, the zone for killing, has to be greater than 13 millimeters, okay, and that's the diameter of the zone that is being created by that antibiotic cyst. And so if the zone of inhibition is greater than 13, then we say that that particular bacterium is susceptible to bacitracin. If the zone is less than 8, then we say that that bacterium is resistant to bacitracin. If the zone is somewhere in between, then we call it intermediate. Okay, so let's say we took bacitracin and we tested Staphylococcus aureus and we got a zone of inhibition of about 15 millimeters, then that would mean that's greater than 13 millimeters. So Staphylococcus aureus is susceptible to bacitracin. Down here, if we look at Staphylococcus aureus and erythromycin, the zone of inhibition is 15, but susceptibility is greater than 18. So this is an intermediate result. And then finally, if we look at things like penicillin G, the zone of inhibition for Staphylococcus aureus is only 10, and that's much smaller than the zone for resistance, so we label that resistant. Okay, so know how this particular table works, because I'm going to give you the first 4 columns, and then you have to tell me whether the bacteria is susceptible, resistant, or if it falls in the intermediate range. You'll be able to fill in the rest of the table. Okay, a lot of times antimicrobials will fail. And there's a lot of different reasons for this. Sometimes the drug just doesn't go to the right body compartment, so it has to diffuse into the compartment where the bacteria are located. Sometimes the antibiotic is ineffective against resistant cells. So, and there are resistant cells that maybe you didn't see in the in vitro testing. And sometimes you'll have a mixed culture infection where a patient is infected by more than one type of bacterium. And so one or more of the strains might be resistant to that particular antibiotic. Okay. The other thing that is really important to determine and I want you to pay close attention to is the therapeutic index. Therapeutic index, or TI, is a calculated value for different antibiotics, and it's used to determine the effectiveness of antibiotics when we're looking at picking the right one for a particular condition. The therapeutic index is the ratio of the dosage of drug that is toxic to humans compared to the minimum effective dose. So that we call that the toxic dose, which is in the numerator, and then the minimum inhibitory concentration, or MIC, which is in the denominator. The toxic dose is the dose that's toxic to humans. The minimum inhibitory concentration is the dose that's toxic to bacteria. And so we take that, and that's the therapeutic index. If we have a high therapeutic index, then that's good. We want to make sure that the toxic dose is much higher than the dose that's going to kill bacteria. If you have a toxic dose, or if you have a therapeutic index that's less than 1, you'll kill the patient before you kill the bacterium. So you want it to be relatively high. Okay. So let's say our minimum inhibitory concentration of bacteria was 9 milligrams per milliliter, or of the antibiotic, excuse me. And our toxic dose, the dose that is going to kill humans, is 50 milligrams per milliliter. So we just simply take the toxic dose, put it in the numerator, and the therapeutic index, and put it in the denominator. I'm sorry, the minimum inhibitory concentration, put it in the denominator, and then we calculate the therapeutic index of 5.56. So that's pretty good, but say if I have a different antibiotic that has a therapeutic index of 8, I would probably pick the one that has a therapeutic index of 8 because it's higher and it's going to be less of a threat to humans. Okay, it'll be able to effectively kill the bacteria without causing harm to the human host. Okay. We also have to look at the existing condition of the patient. So does the patient have some type of pre-existing condition? Have they experienced allergies to this particular drug, like penicillin or amoxicillin or augmentin? Do they already have organ damage? Are they a heavy drinker? Are they a heavy smoker? Do they have damaged lungs? Do they have damaged liver? Infants, elderly, and pregnant women, you don't give pregnant women antibiotics. If they get a bacterial infection, usually they just have to wait it out. Infants, you have to be very careful with, especially because of drug allergies, and obviously elderly patients. You have to look at other drugs that the individual might be taking, drug incompatibilities. You have to be careful with antibiotics and birth control because antibiotics can suppress birth control and render it ineffective. And then genetic or metabolic abnormalities of the patient, like diabetes. Diabetics, you have to be very careful of antibiotic use. Okay. What's the site of infection? And how are you going to give the drug? Is it oral? Is it injectable? Is it a topical? What is the way that the drug is going to be given? And then also cost of the drug. A lot of times your physician or medical provider will give you a generic, and generics are much cheaper than brand name drugs. Brand name drugs have been patented and the patent is still effective, and so they're going to cost more. So if a generic drug, that's just a drug that has come off patent. If a generic drug will work fine, then a lot of times your provider will just mark a little box on the prescription that says that a suitable generic is fine. Have to be careful with the overuse of antibiotics for a number of reasons, and lots of antibiotics are given out in the United States. Many of these are for viral infections, and like I said before, viral infections are not treated with antibiotics. So antibiotics are worse than ineffective because they're actually causing side effects to the patient. They can make them feel run down, they can cause organ damage, they can cause seizures. And so if your practitioner sends you away without an antibiotic because your infection is viral, they are actually doing you a favor. Okay. A lot of times a physician or a medical provider might be wrong, and they may not specifically test for the presence of bacteria. And also broad spectrum antibiotics can be really dangerous because they kill off your normal flora. They put your flora out of balance. That can lead to super infections like yeast infection or Clostridia difficile, as well as other adverse reactions. Again, the whole conversation around generics, we could talk about that for a full lecture, but a lot of times physicians and other medical providers are incentivized to use newer drugs. They're done this by drug companies, but if you have a good provider, then most of the time they will recommend a generic drug just to save money. Okay. Also, exports of drugs to countries with less regulatory control outside the United States, there's less rigorous control in certain countries, and so that can lead to the overuse of antibiotics. And then finally, disposal of antibiotics in the waste supply, will lead to these drugs in food and water, and you don't need to take antibiotics every time you take a sip of water. Okay, so let's do a review. I've gone through quite a bit of information. So you should know what the Kirby-Bauer test is. That's when we just have the small antibiotic discs, and we take the discs and we put them on an inoculated lawn of bacteria, and we see how the antibiotics inhibit the bacteria in a circular zone. MIC is just the minimum inhibitory concentration of the bacteria, or of the antibiotic. And that's just the minimum amount of antibiotic that's going to effectively kill the bacteria that is causing the infection. Therapeutic index is just the toxic dose divided by the minimum inhibitory concentration. And when we have a therapeutic index that is higher, that's better. We always want to make sure a therapeutic index is well above 1. And if we have 2 antibiotics and one has a higher therapeutic index, we want to use the one with a higher therapeutic index. Okay, and the 3 major considerations are the type of infection, the state of the patient. You know, what are they, infant? Are they elderly? Are they pregnant? Do they have some type of organ disease? Are they diabetic? And then finally, the cost of the antibiotic. Okay, and that concludes chapter 12, and that concludes this first video lecture. There will be a second video lecture that I'll get up on Moodle, or excuse me, I'll get up on my web page or my YouTube page just as soon as possible.